Thank you very much. First, everybody for coming on time, and then whoever joined, inshallah. So it gives me great pleasure to introduce my dear friend, my class fellow from AKU, Jamal Rana. Jamal is an assistant physician in chief, chair of medical specialties and interventional services at Kaiser Permanente Medical Center in Oakland, and an adjunct investigator with Division of Research. He has a long-standing research interest in preventive cardiology with more than 225 publications. Areas of his research interest ranges from cardiometabolic disease prevention strategies in large population, lipids, polygenic risk to cardiac imaging. He did his research fellowship at Harvard Medical School and medicine residency at University of Pittsburgh. He completed his cardiology fellowship at Cedars-Sinai Heart Institute, including an additional year of advanced cardiac imaging. He is past president of California American College of Cardiology. Thank you very much, Jamal, for accepting this invitation, and all over to you. Thank you.
So thank you everyone for having me today, and I'm really thrilled. And I was looking forward to for this opportunity कि मुझे पाकिस्तान में आप लोगों के साथ ये थोड़ा बहुत शेयर करने का मौका मिला. So I work in the Bay Area, so I wear several hats. I'm not like my primary work is not just research or just being a preventive cardiologist. I'm a full cardiologist, work clinically everything. But I have a long-standing interest in preventive research, and that's my interest in this area. So I'm going to talk, it's a long agenda, but I'll try to keep things very simple and big picture so that people at least have some practical tips and pearls to take away from them and not make it super complicated. I'm going to talk about the first step of how to do the risk assessment and the importance of LDL goals. Even in America, I live in Bay Area, there are Stanford community doctors and UCSS rheumatologists, even they are not up to date in lots of these things. So that's something people are doing all sorts of cool stuff like TAVRs and CTOs and all this stuff. But when it comes to basics of preventive heart disease, not everybody is up to date. So my endeavor would be to share that with you, all of you today. Next slide. Oh, actually, I want to acknowledge Nathan Wong and Khurram Nasser, who I interact frequently about discussions and on this topic. So I do want to acknowledge them. So that's me when I was, I think, 3-4 years ago. I tell everybody I'm from Pakistan. I'm very proud of my identity. So I thought this is a fun slide. I was born in Lahore. Then I went to Karachi for Afghan University. Then I moved to Boston. And Boston, I was there for 3 to 4 years. I took my boards and I got interested in research. The research at Harvard became really, really interesting. So I ended up spending extra years to make sure that I finish all my projects. In the meanwhile, I was reached out by University of Amsterdam investigators for cross collaboration. So I ended up flying back and forth and virtually end up doing a PhD with the University of Amsterdam with John Castellane, who's very big name in lipids. After that, I was in UPMC Pittsburgh for residency. Then I was in Cedars-Sinai in Los Angeles. And then my wife told me that you cannot go back to any place where there is snow. She was it's Pakistani, but was born and raised in Dubai. So then we ended up staying in California. And now I'm in near Bay Area, San Francisco area, and with Kaiser Permanente, which is, it's important to understand where I practice because that's what's very intentional. Kaiser Permanente is what we call integrated healthcare system. So we have 4.5 million patients, and our system just gets money, and our job is to take care of the patients. We don't get extra money for doing extra TAVRs or extra bypass surgeries. We just get this lump sum money. So it's in our DNA as a value-based care to make sure that as a whole population, we're providing them the best hypertension care, the best diabetes control, the best lipid control up front. So systematically, we are set up for that, which is very unique. Otherwise, in America, it's fee for service. The more you do, the more money you make. But whereas where we practice in Kaiser Permanente, it's all about preventive cardiology. And we do the most TAVRs in Bay Area and all that stuff. But still, that's part of the reason I start practicing here. So atherosclerosis lipids can be very complicated. This is just a snapshot of all the things that happens, and I'm certainly not going to bore you with all these details, and each one of those slides could be a separate grand rounds. But I'm going to keep it very, very practical. So here's the thing. The fundamental thing is that question of LDL-C goals. What happened was that back in 2013, ACCHA guidelines came, and they were very, very dogmatic and very puristic about, hey, we can only follow these randomized clinical trials, and since the trials use the statins, low dose, high dose, so they changed the whole paradigm of treating atherosclerosis for LDL goals, and they just made it, anybody who has disease, just put them on a high dose statin and you are done. And that has really affected our clinical care of the patients, because all these other trials have been showing that the lower the LDL, the better it is. So that's the sort of background of why there's confusion about, in 2025, people are still not clear what kind of LDL goals we have to do. So this is, I love this slide. This is sort of a whole sort of history of how the journey of LDL goal started. So back in 1988, before me and Babar were in med school, and ATP1 guidelines came out, and at that time they said LDL goal should be 130. And then, the good thing is these guidelines keep getting updated, but do take times. Every 4 to 5 years, sometimes 10 years, something gets updated. But long story short, the guidelines follow very closely between American and European societies. And as you can see, as you come closer to 2016, 11, USA was not saying LDL goal should be 70. European was ahead of us. And then it took us by 2018 or so that there's Americans also started talking about lower the LDL better, and LDL goals came up. The point of this is that historically, that 2013 guidelines was a big setback for us to move away from this thing of lowering to a certain goal. I'll give you an example. When you are treating hypertension or diabetes, you don't say, okay, let's just put somebody on blood pressure pill and forget about it, or let's put somebody on metformin or insulin, forget about it. All these physiological measurements, there is this tracking, and there's this thing of reaching these goals. So that's the sort of the background we're working with. Next slide. So coming to the basics again, in USA and even in Europe, in primary prevention, when somebody comes to your clinic, how do you determine that they should be on a statin or they should be treated? We don't want to put every single person that walks in our door on a statin up front. So for that, they have these risk cohort equations. So there used to be Framingham risk score, and then there's this ASCVD pool cohort equation came. Basically, it started estimating 10-year of risk at starting age 40. And then what you put in is, usual stuff. There's age, sex, smoking, systolic blood pressure, cholesterol levels, all this stuff. So you put those things in this sort of risk calculator. They're all available online. In our system, they're embedded in our Health Connect, or what we call like electronic medical records. And then when patient comes in, you put those numbers and gives you this number of what the risk could be. In this example, the 10-year risk, for example, is 13.9%, and they say, well, that's big enough that somebody should be given a statin. So this is from primary prevention, population level, whoever walks through your door, in primary prevention. The big update is this, that in last year, they came up with a new risk calculator. It's called Prevent. So just for that, you guys know, you can look it up later. So just remember now, there's a new calculator now. It's called Prevent. And the difference is that it lowered the age group from 40 to 30 because, the risk starts earlier. So they lowered it to 30. That's one. Number two, it also has an option of 30-year risk calculation, not just 10, because 10 is a very short horizon. Somebody could be low risk at 10-year, but when you keep following them 30 years, the risk is accumulative. It can happen later on. And the third thing they did was they added kidney disease. So that's an important topic today because we have a case later today to discuss too, and added other metabolic stuff in that conversation that those are risk factors of cirrhotic too. So those should be accounted for. So prevent, just remember that that's the upcoming thing. And it's not part of the actual guidelines because guidelines are coming next year, but I'm just telling you in advance, it's going to be part of that. And again, this is the same concept. It's simple risk factors: age, sex, HDL, blood pressure, BM, the usual, the risk factors that we think of. But as you can see, that it also has UACR or kidney function in there, and then there's a new concept about zip codes and social societal, like poor rich sort of thing that can happen too, and you can calculate the risk. So next slide, please. So this is something which is again available in our guidelines, and it gets really confusing, but I want you to focus on the top part. As you come down, you have this age group of 40 to 75. That's when it really starts. This is the ASCVD calculator, the previous one, the pool code equation. As you come down, based on all the risk factors you calculated, you could be low risk, no treatment, and high risk, more than 20% risk of heart disease in 10 years. Treatment, it's very easy. So when you have high risk, I think to make all these things to simplify, instead of saying, oh, let's lower the LDL by 50%, and who is going to calculate all this stuff? It's 50. Just what I practice now is that if somebody's high risk, go to LDL goal of less than 70. And again, this is primary prevention. If they're intermediate risk, goal should be less than 100 milligram for the LDL control. And then you see this borderline risk between 5 to 7.5%. In that they say, well, you could have a discussion. If the patient wants to be aggressive about their care, you can start the statins. If they're not, you can hold off. Or you can consider other things. On the left side, there's this concept of ASCVD risk enhancers. That's again a very good learning sort of concept that AHACC recognized, that family history was not part of it. So if somebody has a family history, somebody has chronic kidney disease, somebody's South Asian. So South Asians actually considered a risk enhancer now. And then again, there are inflammatory disease such as rheumatoid arthritis, HIV, and ethnicity, as I mentioned, South Asians. So when these things are there, then you are more likely to convince the patients to start on statins and not undertreat them. So this is the sort of the big picture concept for primary prevention. Okay, taking my time here just for all of you to sort of absorb this because it's a very busy slide. All right, so next slide. So now this concept of secondary prevention. So secondary prevention is something that we as cardiologists see mostly in our clinic. So somebody who's already had a stroke, MI, heart attack, they come to us. So what they have done is this, and this is the 2018, I mean, it's already 7 years for this, divided into two parts. So one is, again, they I don't know why they try to make everything so complex, but I'll try to like simplify it for you. So they can make it, there is not very high risk and very high risk. But the goal is that as soon as somebody has a stroke or heart attacks, you start with the maximum statin dose. That's the class 1 indication. And then they have all these color-coded stuff. But I think the bottom line is that you should treat them to goal of less than 70 of LDL-C. So that's the main goal. And then over there, they have also introduced these concept of that if somebody has started, let's say, 160 of LDL, and they just a stent was placed in, then you put them on full dose of a statin, and if the LDL comes down to hundreds, it's not still at 70, then you can add ezetimibe or Zetia, and then that's a cheap medicine here. It's generic now. It's a pill. It's easy to take. And if that is not also working to let patients come down to less than 70, then you add PCSK9 inhibitor injections. So, Barbara, do we have PCSK9 inhibitors in Pakistan yet or not?
Jamal, PCSK9 inhibitor, in the sense it was small inhibitory mRNA hai, insulin hai, but pretty expensive.
Oh, there is. Inclisiran है, अच्छा, okay.
But it's pretty expensive and it becomes, yeah, but we do have it available.
Okay. Yeah, so I think, the reason I totally understand that, right? So I don't want to come from this thing, oh, we have to do this, we have to be realistic, what's happening. Pakistan is a country too, so I've practiced this, I know how it is. So PCSK9 story is this, that initially when they came out, they were, I think, around $12,000 a year, and nobody could use it even in America because insurance would not pay for it. So they had to really cut down the cost to $4,000 to $5,000, and only then insurance would cover it. And Intestine is similarly very expensive, even in America, and insurances are not even covering it right now because the outcomes data is not there. So I think for practical purposes, if you can do the maximum dose of a statin and you can do Zetia, which is cheap and very available, then that's the way to go. Next. So what is this, the whole confusion about the very high risk? I don't know why it makes it a lot like big simplicity. So what they're telling you in slide is this, that if you have very high risk, you could focus on 2019. Now suddenly they're talking about the LDL goal of less than 55. So in my mind, most of our patients' goal should be less than 55. And how do you define very high risk? Basically, anyone, now the lower part of the slide, you could see history of multiple ASCVD, which is stroke or MI episodes, and multiple high-risk conditions. So even if somebody has one major ASCVD event, and then look at the high-risk conditions, age more than 65, diabetes, hypertension, kidney disease, smoking, history of heart failure, that's like 80% of our patients. So instead of just, in your mind, calculating all this, I think in my mind, when you have a sort of an older patient and they have all these factors, so the goal more and more is actually goalpost has gone from 70 to less than 55. So in your practice, I think if somebody is not reaching less than 70, then it's really incumbent upon all of us to make sure they try to get to 70. If the medicine is not working, they need to lose weight, they need to take care of their diet, they need to exercise, all those things. And then ideally, I think for better sort of long-term outcomes, you go for less than 55 now. So next slide. Again, this is more of the same. 2022, things move really slowly. Again, they're telling us the same thing that Europeans was telling us some years before. And you can see that there's a mention of inclisiran and bempedoic acid, and I'm going to talk about them in a minute. Okay, next slide. So what's very interesting here is this, that in this slide, you could, again, busy slide, but again, I'm really hammering the point in that as you go to the far side, to 2022, the LDL goal is less than 55 now. So again, that's exactly what I just mentioned. But they're saying that lipid is from India, which is, South Asian, similar genes and higher risk. They're even calling for less than 30 in some patients who have recurrent events. So we do see that. We have patients who come in with a heart attack or stroke, and then they have another event. So I tell you, in my practice, when somebody's LDL was going to like 10 years ago, like going down to 50s, the nurses would stop the statin on them. Oh my God, it's too low. So other one big major learning or sort of teaching from today is that do not worry about the low LDLs. People who were living in caves, their LDLs were in 20s. When children are born, their LDLs are 15, 20. So less than 30 is fine. Yeah, nobody goes to zero, but do not worry about it. And then again, this is relevant to the case that we're going to be discussing. So that's why I thought I'll mention this point as well. Next slide. Now, this may or may not be relevant to you, but I figured that my job is also to sort of give you updates, what's hot right now, what's happening, it's sort of cutting edge, which should not be. I mean, ApoB is one of the a blood test which has been there forever, but it became very fashionable recently because some of the podcasters and some of the lipidologists. So I figured I'll mention that too. So next slide. So ApoB is very similar to non-HDLC. So non-HDLC, as you know, is basically total cholesterol minus HDLC. So in all our reports in Pakistan and America, you get a simple lipid profile. All you have to do is deduct total cholesterol minus HDLC. You get this non-HDLC value. And that actually tracks very closely to ApoB. So you do not have to do an extra test of ApoB. Yes, if you have resources, you have extra money, whatnot, you can do those things. But I call non-HDLC is, I don't want to call it poor man's thing, but because it's there, that can be helpful. So how to remember the trick? What is the cutoff for non-HDLC? So it's at 30. So if somebody's LDL is at 100, so non-HDLC would be 130. So add 30, 70 means 100, 100 means 130, 130 means 160. So you can aim for lowering of that. So next slide. So this is a study, recent study, came out in JACC, 13,000 statin-treated patients, follow-up was 8 years. Basically, they said that, oh, you know what? ApoB is better than non-HDLC. Yield has a ratio of 20% more. So essentially what they're telling you is that even when LDLC is low, but your non-HDLC and ApoB is high, your risk could be as high as 23% high risk of mortality and high risk of MI. So that's one of those things when you see a patient, when you get surprised by very low, like lower LDLC, and it's like, oh my God, they have all this disease. Where did it come from? So you should think about perhaps we can check an ApoB on them. And then I'm going to talk about lipoprotein A in a minute. Those testing could be further refine your risk stratification. So that's where the value comes in. And you always have non-HDLC there. Okay. So next slide. This is my, during my PhD years, I did this like, I don't know, I even remember, I'm getting old, like 12 years ago. So 12 years ago, long story short, we had 26,000 population and 11 years of follow-up. And on the right side, you could see that survival curves on the top is non-HDLC and on the bottom is ApoB. You can see how similarly they track. So this was a big proof. Yes, if you want to get into minutiae and people have their own sort of labs and stuff, yeah, you can discuss it forever. But just to reassure you that when I'm saying something, in fact, I have my own data to support that. Okay, so next slide. Again, I don't want to like read the whole thing. Basically, what it's telling you is that yes, you can use ApoB, use clinical judgment. If you are thinking that somebody's LDL is not high enough, or and you are concerned, but they have diabetes, metabolic syndrome, then you can further check ApoB to make your point to the patient that hey, you are high risk, and we should be more aggressive about your lifestyle, about your diet, and about getting the LDL levels more aggressively. And then you can track ApoB lowering as well. So this is latest hot off the press kind of things, how we are practicing here right now. Next slide. And the reason it becomes so complicated is that, cardiologists here are having trouble even remembering the cutoffs for LDLC. So then you start adding ApoB, and then people have to memorize these cutoffs. So trust me, when people are busy, so this, in my mind, it just confuses the thing, So now, so next slide. Now, the other thing that's really hot right now, and it's discussed everywhere, and it just blew up in the last 1 or 2 years, and I've really felt that I should share with all of my colleagues practicing, all of you, about Lp(a). And next slide. So right off the bat, it's actually, I don't know how if it's checked in Pakistan or it's not very expensive here. You have it, Robert? Do you guys check it ever or?
चुगताई लैब करता है सिर्फ नो AQ doesn't do it, only चुगताई लैब does it.
तो हाँ उनसे कि देख लो कि उनकी प्राइस ज्यादा नहीं. That's something worth for all of you to start considering checking, adding it to your thing. और काफी सारी companies हैं, they're working on this right now. There's interest in this pharmaceutical companies because outcome studies are coming out, so they can even support some of this work. Okay. So for this one, I think the main thing is that it's different than ApoB. That's my point on this slide. And the next slide will give you again, I'm treating it very sort of, next slide, please, keeping it simple, is that what they're telling us is this, that measure LPA at least once in all adults, once in a lifetime. Even in children, they're saying if there is a high risk for sort of family history or not. Because what they found is this, that unlike LDLC, which can change every few months based on how you're doing, LP little a sort of stays stable for up to 5 years. And it can be you check, you know how I spoke about that when you're doing risk calculation, start at 30, 40. This one you can do at 22-year-old. So genetically, if the LP little a is high, while LDLC is not high as yet, it can tell you that somebody has higher risk, and you can identify those patients and start treating them more aggressively, or at least tell them, hey, don't smoke because you are genetically predisposed to be high risk. So I think this is a very powerful test that, and I really am a big proponent of this. Our number to remember is more than 50 mg per DL. So that's simple number to remember. और पाकिस्तान में तो हमारे हर एक की फैमिली हिस्ट्री है. मेरे वालिद की had a heart attack when he was 47. मेरे सारे चाचा थे, they all have line से heart attacks in their 40s. So almost everybody has family history. So we really have to overthink this thing. So that's something I think, something to consider to promote in Pakistan. Okay. So next slide. Okay, now I think we can go to part two, and I'm staying on time.
This is excellent, Jamal. A quick question until
well. Absolutely. No, I'm just anytime. Yeah.
Are there any medications specifically targeting ApoB and lipoprotein(a)?
Yeah. So I was going to come to that. So ApoB, there's no specific medication. It's actually ApoB comes down with statins and PCSK9s and all those things. Lipoprotein(a), they are actively, many trials are happening right now, which have shown even that the initial trials are that if you treat them, Lp(a) is going on, but the outcome studies are not back yet. So obviously we have to wait for the outcome study before we start doing them, because all these medicines are going to be very expensive. So I think it's on the horizon that 3 to 4 years, there will be something here. But for our purpose, in my mind, I think if there's a young person, we can already start telling them, don't forget the lifestyle, smoking nahi karo, try to take care of your pre-diabetes and all those stuff. So let's come to your point. This is a good segue. Role of non-statin or /newer medications. So next slide. So this is something, Babar, you were discussing. This is not something that Pakistan mein hai, India mein hai, America mein bhi exactly ye ho raha hai कि people are not at goal. I mean, this is terrible. As I said, it's fee-for-service in America. People are, I call it, in America, we don't have healthcare, we have sick care. So when people get sick, then we treat them, then people make money. So this is healthcare when you know that there is these things can take care of patients' first event or second and third event, and you can see how few patients are at goal even over here. So it's a big challenge even in America. So next slide. So this is I'm going to sort of talk about a little bit this. Nearly all patients with the SCVD can potentially get LDLC, but it's going to take some effort. So on the left side, you can see that patients achieving less than 70%, if you just do monotherapy statin, 69-70% can get that. You add a Zetia, which is a very cheap medicine, now generic, you can get up to 86%. So for Pakistan, even if you can get to 86%, तो मैं तो हर एक को Zetia इकट्ठा लगा देता हूँ foreign. Why wait? Why mess around? जाए दोनों शुरू कर लो. Yes, go ahead. You have a Zetia? Yeah.
हमारे पास तो combination medication आती है, तो statin is a combination medication.
So I would say in America, because of the stupid pharmaceutical whatever money thing, they don't have. But in Pakistan and in Europe, we have poly pills or combination pills. So this is the way to go. So even if you're like, oh, we don't have PCSK9, even if you're in 86% people, that's still very, very good. Okay. So I think this is a very, very hopeful slide in my mind, okay, just put everybody on it, go less than 70, and your work is kind of done. Okay. I would not recommend कि आप किसी patient को आपको जी के लाखों डॉलर रुपए की आप extra चीज लो. No, that's just not fair for the little bang for the buck. Yes, if they are available, they're cheap, just covering it. Absolutely. I don't want to be misquoted that Dr. Rana was saying that don't give PCSK9 because I do prescribe them. But I'm just sharing with you in America, we couldn't when they were super expensive. So next slide. So I don't want to go into too much, but I want to be comprehensive at the same time. So Zetia, there was an IMPROVE-IT trial, 2015 math. The results were not very strong, but now that it's cheaper, I think it's combination medicine. There you go. We should be doing it. And it's absorbed from gut, so it's different than statins. So it's a complementary thing. Okay. The next slide. Again, PCSK9, basically what they're doing is, bottom line is this, they increase the number of LDL receptors. Look at the bottom of this slide, available to remove LDL cholesterol from the blood. So increase, the more LDL receptors you have, the more they can tie with the LDL and then clean it out. That's their job. And then the trials came out back in 2017 and 18. Again, we are 7 years in. There's such a major clinical inertia, but they didn't. I was talking to a lot of these companies at the time. I was like, you guys making it very expensive. And now they're paying the price literally for not uptake. But now things are changing. So that's that. So next slide. So bempedoic acid, just for your awareness, is an oral pill. And it has a sort of different pathway from statin, that it doesn't affect in the skeletal muscle. So there are no myalgia. So a lot of patients in America say, gee, because they're reading Google and otherwise, we cannot take statin, I get myalgias. So bempedoic acid came out, it showed that it lowers the risk and everything, but without myalgia. So it was a very, very exciting time. There's a Wall Street Journal sort of clip snippet. I was lucky enough to be even quoted in this study, in this news article when it came out in ACC. There was a lot of excitement, but again, the same mistake, capitalism. They made it really, really expensive. So statins now in America is like $1 a month. They're down to cents, right? It's really cheap. And then these people wanted to have thousands of dollars a year. So again, there's no uptick. So the economics of things do matter over there. So I'm sharing it. I don't want you to spend too much money to buy this medicine, but just for your awareness, it's there. Yeah.
Maybe Pakistan में available है, but
This might be cheaper because I've heard India में काफी cheap है ये.
ये काफी cheap है. मतलब it's relatively cheap and it's available in Pakistan.
So ठीक है, you guys are ahead of us. तो इसमें फिर ये है कि if there are people who are statins, because there are people who can't even walk anymore, कि बहुत ज़्यादा myalgias हो रही हैं, सब कुछ हो गए हैं, then this also comes in a combination. So bempedoic acid is called Nextel here with Zetia. So use it. So don't worry about the PCSK9. Then if it's cheap, then definitely you can use it for myalgia. So that's good to know. All right. So next slide. So in inclisiran, it's very exciting. The upside of this is that it's once in 6 months injection. So the upside is this, that adherence is really good. So जब से ये Ozempic और obesity medicines आई हैं, वो जो psychological होता था ना कि we can't take injections, patients, now that thing is gone. But the thing is that it's expensive, it's once in 6 months, and we don't have outcomes data yet. So the uptake even in America is not very high. So, but again, this is exciting stuff. I mean, that's where things should be moving. The results are just fantastic. I have a patient who was actually a surgeon who got 60, but he got a CABG done, and he didn't want to take statins. His LDL is down to 30s just by every 6-month injection. So imagine in the future, 5 years down the pike, if they become cheap and available, all the interventionists will not have a job. Injections twice a year, LDL is walking around in 30. I mean, that's just brilliant. So that's very exciting stuff that's going to happen. Okay, next slide. So this is just a summary slide. I'm not going to bore you with everything, but just it shows that there's these dosages, there's efficacy, your LDL-C. Importantly, Zetia, as I said, is not as 18% LDL reduction, PCSK9, you have 57% LDL reduction and 50% ASCVD reduction. Bempedoic acid is 21% LDL reduction, similar, more than Zetia, a little less than statins, but you can see 13% ASCVD reduction. So it's a good medicine. And inclisiran LDL reduction is 45%, similar to PCSK9s, more than the other medicines. And the outcome data is not out yet. Okay, so I hope I didn't confuse you guys, but I think it's good for our knowledge overall that what's coming up around the corner and actually being practiced right now.
Jamal, compared to like C में efficacy में statins, where do they stand? As in from a percentage reduction, and then in AC,
that's a good question. So full dose, maximum dose LDL C reduction could be 50% with the high dose statin. So that's why PCSK9 is an add-on to the LDL. So when you decrease it first, and then you cannot get to 55, it's impossible to get somebody from 160 to less than 55. That's where you start with full dose statin, and then you add on PCSK9. So PCSK9's role is actually twofold. So I give it to patients who cannot take it because of myalgias, but it's always an add-on. Statin is the sort of the ground at the bottom, like a foundation of everything. And AC risk reduction is similar to PCSK9s to 15 to 20%. So next slide. So this is the case, a very interesting case, 45-year-old male, hypertension because his diabetes, of course, is on dialysis, and family history in a transplant. Very unfortunate. I mean, it just breaks my heart. Such young people, folks getting this, and was found to have triple vessel disease. I mean, knowing Babar, he has to find me the toughest case. So next slide. Okay. Investigation, hemoglobin A1C. So I was surprised because pre-diabetes is very common. So hemoglobin A1C 5.6, started giving pre-diabetes. So this patient even didn't have that. Triglycerides 184, not awful, not 300, not 250. HDL is on the lower side. The higher is sort of normal. LDL is only 42. So that was very shocking and surprising for me. So this guy was just a bad luck for him. But again, remember I talked about the risk enhancers. So CKD, chronic kidney disease, is a big risk enhancer for accelerated atherosclerotic disease. So आप लोगों की तो बहुत ज़्यादा होगी CKD because most of these younger patients are coming with dialysis and stuff, right? So that's a big thing. I've seen arteries. It was like porcelain heart. इतना ज़्यादा उनके early onset atherosclerotic disease होती है. So I think that's one of the things. It'll be interesting to know, to see if we can check in Lp(a) or ApoB for this patient. Just for the academic sake, you can see how was ज़्यादा था या नहीं था. Not that it's going to make a difference right now, but that will be interesting to do. And I think if the learning is here, is even if you have a 42 LDL, I would still put somebody on a statin because it just because अगर bypass हुई है, you still want to make sure that statins have this thing, not just lowering LDL, but pleiotropic effect of stabilization of the plaque. So calcified plaque ko stable karna, soft plaque ko stable karna. So I would still put this person, you don't have to put an 80, but put on something so that LDL goes down to just 20, so your fresh bypasses and they stay open. So I think I would still treat this patient. And you guys are doing that. So we'll start in 20, brilliant. So let no one say, oh, LDL to bahut thoda hai, so let's not treat it. Don't do that. Okay. So next slide. So next slide. Again, to the point that LDL is not the whole story. There's still residual risk, right? So as I mentioned, statins are not enough for residual risk because you could see here that still there were events happening despite people being on all these statins. So residual risk comes from people having hypertension, diabetes, CKD. LDL is part of the puzzle, it's not the whole thing, but it's one of the things that we have treatment and it's one of the main drivers. Yeah. Next slide. I know I'm running out of time here, 5 minutes left. I do want to mention coronary calcium scoring. This is my favorite thing because I think Pakistan. So innovation inertia. So I'm glad you're moving forward. So 1961 में Framingham Race Score में भी वही चीजें थी जो 2023 के अंदर है. Like, come on, so we talk about AI and things like that and all this awesome stuff you guys are doing in SAUT, and then we are stuck with this kind of पुराने जमाने की चीजें. So I think we do echo, we do mammographies. All the women get mammograms at 40. So why not take care of the number one killer in the world, which is heart disease? So next slide. So essentially, so there's so much confusion. Prevent आ गई, but prevent की वजह से वो कह रहे हैं कि now it's underestimating. That's a paper in the middle, my paper in Jack from 9 years ago that also talked about over and underestimation, because I almost call them like guesstimators because they're never perfect, right? So then I think one of the things that could be is that you just see disease and treat disease, as what NASA would say. So next slide. Essentially, I think it's available, calcium scanning and CT angiograms. So calcium scanning, even in America, it's available, but insurance doesn't cover it. So there's still a battle, but it's cheap. It's $75. So it should be not very expensive, basically. If you see disease, so even in this patient, I bet most of your patients will have disease, job treat career for dialysis and stuff. So if you do all their calcium scans, they will all have some sort of sclerotic disease. And then, of course, leads to worse outcomes. Millions of studies have shown that. So basically, what it's telling is that, on the bottom, you see 3.35, the yellows. So even when your LDL was very high, more than 3.35, this is different. It's not MGDL, but the rate of CVD per thousand was still low if your calcium score was 0. So despite having, I'm talking about the really last sort of column or row here, that when your CAC score is more than 100, then your number of events becomes so high. So, and when your CAC score is 0, despite having very high LDLs, then it doesn't happen. And on the flip side, you could see that sometimes when you have very low LDLs, but your calcium score is high, you still have very high numbers. So if calcium score is high, it's very consistently high events. So the case study that we have, even if the LDLs were low, if you had checked the calcium scan at age 40, it would have been positive and would have been a marker that HA disease is coming. Okay. And this is an old study, it's 114, but again, a lot of clinical inertia. Next slide. So this is just to show that the whole world is talking about it now. I'm not going to delve into that. Next slide. So again, simplifying it, what it tells us is that you do a calcium score 0, unless somebody is smoker or diabetes, we don't treat those patients, and you can always repeat the calcium scan. If the calcium scan comes to 1 to 100, then don't overthink it. Don't put risk calculators. Just say, hey, you need an LDL goal of less than 100. And then if somebody want to be more aggressive, less than 70 is optional. And then CAC score, if it's more than 100, then I would say that you not only aim for LDL goal of less than 170, but you even put a baby aspirin on top if they're not high risk. Because there are studies that have shown that when LDL is around CAC score is around 300, the risk of recurrent ASCVD, recurrent heart attacks were very similar to the patients who already had stents placed. So it's almost like secondary prevention. So I don't even call it primary prevention. If your CAC scores are, you have disease, so it's like secondary prevention. So be aggressive. So in my practice, what we're trying to say here is that anytime somebody is turning 40, because before 40, the plaque is non-calcified, so you miss. So above 40, or let's make it 45, whatever. So I have, even here, I live in the Bay Area, there's lots of South Asians, techies, CEOs, CTOs, whatnot, and they are dying. Like somebody was hiking and died while hiking. Somebody didn't wake up in their sleep. LDLs is fine. They're 55, 45, but they have coronary disease because they're South Asians. So I believe that if it's cheaper and if you want to do one thing, then this should be a screening tool, and forget about all those risk calculators and whatnot. Again, this is not guidelines. This is my sort of personal thing, and that's what makes sense, And next slide. I think I'm really close to the end here. So take-home message is, just to summarize, it was a lot of things I covered. That assess the risk, prevent is the main thing to remember. Do calcium scanning where available. If it's not available, you can go back to the risk calculators. Never forget the emphasize heart healthy lifestyle. I forgot to add a slide. There was somebody sent me a slide उसमें लिखा हुआ था, पीछे लिखा हुआ था कार्डियोलॉजी इंस्टीट्यूट, और आगे मेन्यू लगा हुआ था कि वो नहारी और पाए और हलवा पूरी और उन सबका. So किसी ने वो लिखा हुआ था, this is called job security. And it's not a fake photo. I forgot to do it. So you have to talk about lifestyle too. Literally, the cardiology institute और आगे नहारी पाए का नाश्ता पाए वो जितने का भी था वो. So that's a really big thing, So it's uphill battle, जो हमारा खाना है, lifestyle है. I mean, I love Bangladeshi food. I really like it, but it's so hard, right? So, and then once in a lifetime of lipoprotein है. Okay, and the next slide, last slide, next one. Again, I think I really couldn't say that enough, that just remember, keep it simple. Remember 70, and if you can, less than 55. ZTR combination is your friend, use that. I think based on what I've learned from all of you today is that don't feel bad about PCSK9 too much, because if you can get 86% of patients less than 70, your job is done. And then bempedoic acid is, if it's available, it's getting cheaper, then that's an alternative there. So I will stop there. So I hope I can continue to contribute in whatever I can, and I really mean it. So thank you, everyone.